I've worked at New England Baptist prior to that, and with that group, we've been very concerned about the sort of fairly aggressive way people have dished out opioids for various musculoskeletal pain problems. And sometimes it may seem appropriate, and other times it seems to get out of hand. So we really have to think about that. I'm currently on the Norfolk County Safe Prescribing Clinical Work Group as well. And we might see Dave Morgan. I think he was going to come, but maybe he got tied up. And he's a pharmacist who leads that group with the DA's office in Norfolk County. They were recipients of a grant came from Hal. Let's see, from forgetting his name now. Anyway, the representative from Kentucky who sponsored some money for research in this area so that we could spend more time getting doctors to use prescription monitoring programs and other things like that. And unfortunately, Norfolk County is one of those counties that is having such a big problem that they qualified for the grant. And there were only 3 other counties in the country that got that grant. So this is very close to home. So how did we get ourselves into this mess? So way back in 1986, the World Health Organization was really pushing opioids for treatment of cancer pain, really felt that cancer pain was being undertreated. And so there was a big push to get comfortable with prescribing opioid medications. But then they got the idea that, wow, this is something that might actually help our musculoskeletal pain patients. So in short order, there was, make sure I don't turn this off now. Let's see, is it the on? Okay, so they started using opioids for mild to moderate pain and non-cancer pain. And this was the big change, the big shift. This was pushed forward in the 1990s. And that's about when OxyContin hit the market. But so the VA launched its initiative to treat pain in 1999, where they were asking everyone, what is your pain level? And JCO followed suit. And so they have hospital people now. If you go to the hospital, you're asked, what's your pain level? 0 to 10, let's treat it, let's be aggressive. And you're not being adequately treated if you have pain of a degree that's uncomfortable and so on. So the American Pain Society guidelines in 1996 came out right as OxyContin arrived, and OxyContin was very aggressively marketed at that time. In fact, this is something that I think will probably be worth a lot in the future. The OxyContin rep gave me this cup, okay, back in 1996, I think. I was starting my practice. I'd never heard of the drug. And this was very promising because it was long-acting, it was slow to onset, no abuse potential, right? And it says the one to start with and the one to stay with. So taking a couple pictures here, sent these around, and people are pretty surprised that this is how it was marketed. So is it a compassionate response to pain when doctors are prescribing this? Or is it a public health crisis? And so we have to try to remember that some people are caught in the middle of this, where you have pain, you want it treated, effectively, and you've heard that, well, this drug works or that drug works, and so, you expect that now. It's an expectation that we should not have to suffer in pain. But on the other hand, it's really not that simple. Does it really work? And does it really work for our various aches and pains that it's being used for now? So this is what's happening now. The motor vehicle crash deaths have declined. The cars have gotten much safer. You've got the airbags and so on. And poisoning deaths really took off, and it's because of drug poisoning deaths, not because of kids getting into the lye or whatever. So it's drug poisoning deaths that really took off and surpassed motor vehicle crash deaths in 2008. That's when the two crossed, okay? And so you look at actual drugs, and you look at any opioid analgesic, that's the one that's really the steep curve here, as opposed to other non-specified drugs and other types of things that you could overdose on, okay? And if you look at methadone, you think of methadone as being dangerous, but that kind of leveled off. It wasn't all methadone. It's this natural and semi-synthetic opioid analgesics, the ones that we hear about. The OxyContins and hydrocodone, morphine, et cetera. And then some of them are the synthetic ones, which would be like fentanyl patches, things like that, okay, that people are abusing. Think about the age. Yes?
Could you just define an opioid?
Oh yeah, good idea. Opioids are derivatives of the opium plant, and they're strong analgesics, and they can cause respiratory suppression. And so all of these drugs are considered opioid analgesics. Your morphines, hydrocodones, oxycodones, even codeine is a derivative. So you've got and fentanyl patch, things like that, are synthetic opioids where it's just been manipulated in such a way it's created in the laboratory. Okay, so all of these things can cause respiratory suppression. They can lead to dependence and tolerance, and we'll get into a little more of the issues with that. Anyone else want to add to that? Yeah. Okay. So if you look at the age groups, you would think it would be the young people, right, that are abusing. And it's not just abuse, it's overdoses and things. So overdose deaths actually peaked among people in the age groups 45 to 54, okay? And the younger people, 25 to 34, half as often as middle-aged people. Dave, thanks for coming. Okay, this is Dave Morgan, I mentioned. He's with the Norfolk County, the Safe Prescribing Group, and I'm part of that with the DA's office. So I think there's some seats back there. You want to sit up front? I don't care. Yeah, good. Go up front. Yeah, you might have something to add, I'm sure. Great. So anyway, but it's young people too. But this is nationally.
Would turning one of these bank of lights out be helpful, do you think?
Well, then I won't be able to videotape.
Yeah, why don't you leave it on?
Leave it
yeah,
on.
Okay,
leave it. That's fine.
Rob's videoing. Okay.
Right. Yeah. So this age group here really surprised me, and it surprised people involved at the CDC and other places too. And so and NIDA, which is your National Institute of Drug Abuse, they were looking at these numbers thinking, gosh, it's not just people abusing drugs, it's people taking drugs as prescribed. And that's what we've discovered. So some of the overdose deaths are from people, and about, I think one study suggests it could be up to a third of the deaths are actually people taking as prescribed, okay? And what happens is that they take it along with other medications that they're on, and the antifungal medications of all things actually cause the medications to be accelerated, like it decreases the metabolism of the drug, so it ends up being stronger than it would otherwise be. And so what it can also happen is you add that to medical problems like sleep apnea, obesity, and other things, and combine that with other medications for depression and anxiety, then you've got trouble. You're asking for trouble. So that's part of the problem too. Now, if you look at Massachusetts, and this is a little more current, we're seeing that the people in that 45 to 54 age range, that peaked around 2006. That would be this aqua color here, and then that has come down. And in fact, it is younger people in our area that are suffering more from problems with the highest rates of death, actually death rate. So that the young people are dying, and we have to do something about that. So. And it does correspond to the number of sales. So if you look at the sales of opioid drugs and you look at the deaths, it corresponds. And then the treatments, need for treatments, and so on. But unfortunately, the treatments haven't kept pace, considering how many deaths there are, and that's just the tip of the iceberg, and we'll get into that in just a second. I do want to show you this. This is monitoring for the future, and it's done at University of Michigan, out of Ann Arbor. And what they do is they survey hundreds of schools, high school students, and they track their drug use and their awareness of drug abuse and their thoughts about it and so on. And I'm just going to show you a few slides. There's a ton of information about all sorts of drugs on here, but I picked just a couple slides, and this is OxyContin use among 12th graders, for instance, and 8th graders. So you even have a couple percentage of 8th graders using OxyContin, not as prescribed. But in the 12th grade, you'll see, closer to 5% are using this. And why are they using this? Because they have access to it, okay? And then Vicodin use, that fortunately is starting to drop down a little bit. We think this might be because of prescription monitoring programs, we're not sure. But this is the only hopeful thing that we saw when we were in Atlanta at the National Prescription Abuse Summit. But anyway, this number is dropping down. 12th graders, though, look at that. 10% of 12th graders were using that in the last 12 months.
Yeah, these are non-prescription uses.
Yes, right.
Is that nationally?
Yes, this is surveying about 400 schools nationally. Yeah, yeah. And then this is kind of scary too, because it says the 12th graders, 50% of them said it's fairly easy or very easy to get these drugs. So they know where to get them. I mean, 50% know where to get this stuff. All right? So, but it's mixtures of these drugs. It's not just one thing alone. It's sedatives, opioids, and alcohol. Mixtures of these drugs is what kills people. And so if you're looking at this one study from Ontario, more than 600 people who received opioid prescriptions, there was about 1,500 opioid-related deaths, and I forget what percentage that was. It's less than 1%, but still it was a significant number of people dying. And of those, they do toxicology screens, and so most of them had more than one type of opioid, or like 40% more than one type of opioid, or they had benzodiazepines, which would be your Valiums, your Klonopin, those types of things in their system, and 20% had alcohol too. So it's combinations of things that really kill people. And then we look at the deaths. The one death is associated with 15 abuse treatment admissions, 26 emergency room visits, 115 who abuse or are dependent, and 733 non-medical users. Okay, so non-medical users. And if you translate that to numbers that pertain locally, we know about 62 deaths.
61 deaths in
61 deaths.
2013. So
Yeah.
if you do the math, 60 times 700
733.
is around 4,200 people. So
Yeah, 42,000.
um,
Yeah.
42,000?
Mhm.
Okay, so 42,000 people in Norfolk
In
County
Norfolk County,
are
non-medical
using drugs non-medically. So
Right.
that's a lot of people. And so Norfolk County is a county of 30 towns and 600,000 people, so it's significant. So that one death translates to all those others. So
Right. So Tom Frieden is the head of the CDC, and he's very concerned about this, and he sees this as a crisis, opioid crisis and health crisis. He also is stated very clearly that opioids are not safe in people with chronic musculoskeletal conditions, and they really have not been shown to be effective, and which is really interesting. So what are the costs, the disability rates, the functional outcomes? So what I mean by functional outcomes, it's like the return to work or activity. Okay, return to life. Do these drugs bring people back to life? Do they get them back being more active again? What are the functional outcomes of people on these kinds of drugs? Should doctors accept that people make bad choices, all right, outside the exam room, and just take them at their word? Are these societal problems? Are they beyond the scope of a doctor-patient relationship? And these are the kinds of discussions we have in doctor meetings and things like that. And it's complex, but I'd like to take it back to this again. So it's not just about trusting the person sitting in front of you. If they're somewhat impaired or they're anxious and they're concerned and they're in pain and so on. It's really, does it work? Okay, let's be objective. Does it work? And that's where we haven't seen as much improvement as we would like to think. Okay, so focus on functional improvement. We can't just treat pain. We have to focus on enhanced mood, improved sleep, distracting from the pain, so keeping busy, keeping your mind active, using ice or heat, anything to try to distract from the pain. And also provide a more realistic outlook. I mean, it's kind of normal to have a sensitive nervous system and have pain and various aches and pains as we get older. So what can I expect? Can I expect that this will go away in a short period of time? And usually acute pain will subside in a relatively short period of time. And we know from other studies that injured workers, like in Washington, D.C., or in the state of Washington, they have a really good database looking at injured workers. And if you look at these people over a year and where their opioid dosage was increased, less than a quarter reported a mere 30% improvement in pain and function. And these are by looking at certain scales that they do and in terms of how they report out their sitting, standing, walking tolerance, and so on. So very few report any improvements. And it's kind of a difficult thing because they become dependent in a way on the medication, and they might not be addicted, but they're also in that gray area. So there's a lot of people in the gray area where you're not necessarily benefiting that much from the medicine, but getting off of it makes you feel sick, makes you feel lousy. So there's a lot of people in that gray area, and it could be tough trying to talk to them about function when you know you're going to feel sick if you come off of it. So they have to report pain to their doctor in order to get the medicine. So.
Johnny, are there other medications that can relieve pain other than, that are more effective in terms of?
You know, there's medications, but yeah, there are some, and usually people don't find them as effective as the opioids, and that's the dilemma. You know, it's like whenever I mention a whole host of medications to patients who are clearly dependent, they say, oh, I've tried that, and that just made me feel crummy, and blah, blah, blah. You know, so it's really tough trying to find something. Usually they have to be off the opioid for their body to sort of reset, and for them to be sensitive to a different class of drugs. So it's tricky. But anyway, we know that certain doses of morphine, and we talk about morphine as sort of the base, and then you translate that to oxycodone and these other drugs. So this would be equivalent to about 160 of oxycodone, for instance. 3 times the risk of death if you take that on a daily basis. If you take, let's see, so morphine dose of 50 would be about 40 oxycodone a day, twice the risk of death, and just 40 milligrams of oxycontin twice a day, which is a moderate dose. It's not a light dose, but it's a moderate dose. Your overdose risk is 9 times what it would be if you weren't on it. Okay, so I mean, just or greater than, yeah, with that amount of OxyContin. So these are substantial risks that we're taking if we're on these things, or if we as doctors are prescribing this. So we know that use of opioids early after a back injury increases risk of long-term disability and surgery. And it's like, is it because it's a more serious injury? Maybe not. And so there's a mental part to this too. So the fact that you need a strong drug for your back condition sort of reinforces the fact that you think you have a serious back condition, and you're probably going to get more scans because of the serious back condition, and therefore you're going to find someone who might want to operate on something that they think might be fixable. Okay? So we know that more scans, more knowledge about what's going on in the back in terms of the aging process and the disc herniations and all that can actually lead to more treatment that may or may not be effective, when if you just didn't know and you just let it alone, your body would probably adapt a little better. Okay? It's not always the case. There's definitely a tipping point where your body can no longer adapt, and surgery is going to be a really good thing for you. But there's enough people in that in-between area that, you know, the more you take, the more serious you treat it, the more injections you get, and so on, it tends to sort of snowball, the whole process of you know, making it seem more important than it is. You know what I mean? Following that? It's kind of tricky, but it's true. Okay, 7 days, more than 7 days, or 2 opioid prescriptions early on after a back injury doubles your risk of disability at 1 year. That's been shown by a study. And this was adjusted for pain, function, and injury severity. So they had people that were matched, and so that just means that, you know, if you compare it to a group that wasn't on the opioids, the people in the opioids did worse. Okay, and that's how that works. The other reason, you know, different jurisdictions and governments and workers' comp and insurance companies are concerned is it costs a lot. These things are not cheap. Okay, so in 2002, about 4% of the payments that went out for workers' comp injuries in California was about what was on these opioids, and prescription opioids or Schedule II opioids. But in 2011, after all this push to treat pain and the marketing and all that, more than 20% of their costs were due to these long-acting and short-acting opioids. So it's a very expensive problem we've gotten into too. So this is a little shift now. I want to just sort of present this idea that fear avoidance beliefs plays into how we cope with pain. And this has to do with, like, pertaining to the spine, it would be if you have a very high fear avoidance beliefs, you have disproportionately strong beliefs about the importance of the back pain and the vulnerability of your spine. Okay? Doctors have a fear avoidance belief for their patient too, which means the stronger a doctor's fear avoidance belief is about how serious their patient's back condition is, the more likely they are to prescribe medications and to order lots of scans and to do more treatments. So it's our beliefs influence our response to pain. Doctors' beliefs influence their response to their patient's pain. So there's a whole range of this. So if a doctor, for instance, has high fear avoidance beliefs, there's more restrictions or limitations, fear of any bending or lifting. They want to protect you. They want to protect your spine. You as a patient might assume more of a sick role, and you might become more dependent on strong medications or other interventions. Following that? Yeah. Okay, good. And then there are adverse effects of opioids. We don't need to list them all. If I really want to get into it, one of the most serious ones is constipation. And it can be serious. I mean, it can lead to bowel obstruction, surgery, and things like that. Men, if I really want to help them not want the medicine, I just tell them it'll shrink their gonads. So there are, lots of things that it can cause. So, and when they list the review of systems and they check every other one, they get dizzy, they feel depressed, they feel moody, they feel confused at times, they get, chills, and I'll tell them, gosh, you're on a lot of medication here. Medication might account for all of this, all of these symptoms you're having. So, it's another way to kind of open up the conversation a little bit, at least. But we know that now that the medication can backfire, it can cause hyperalgesia, which means hyper pain, like an increased response to a stimulus that is normally painful. So, like if I were to push hard on your back, it doesn't take much for someone on an opioid to jump, okay? Actually, it can be what's called allodynia, which is a stimulus that's not supposed to be painful. They'll jump. And this is like a sensitivity of the peripheral nervous system that develops as a result of the medication. And I think this is more common than we originally thought. I think it can go along with tolerance as well. So this is another reason I can usually open up a conversation with the patient about maybe weaning if in fact, I touch them and they jump. It's a sensitivity in the nervous system that can occur. It can occur without opioids. People with chronic back pain can have that same sensitivity. It's almost like fibromyalgia, where you're just sensitive all over, which is another type of painful disorder where you just kind of hurt when you touch different spots. So that's pretty common. It does tend to lessen a little bit if you get off the medications. Tolerance is a state of adaptation whereby you take the medicine, works for a while, but then it doesn't work after a while, and then you have to take more to get the same response, and you keep going up and up and up. And then you start getting into side effects, and that's where you can run into some trouble. So we've just, in summary again, we talked about the poisoning deaths. It's now the leading cause of accidental deaths. It's, it's 37,000 versus 35,000 motor vehicle crash deaths in 2010. Huge increase in these deaths in the past decade. It's not just the deaths, it's the people that are suffering out there, the many, many hundreds of people that are suffering. So if you're in the doctor's office, you need a medication, don't complain about having to sign a narcotic contract. This is just to keep everyone safe, okay? You just have to stick with one pharmacy, one doctor prescribing these drugs so that they can coordinate care and keep it within the safe range. Pill counts would be appropriate. I mean, doctor doesn't know who's going to go out and do the wrong thing and sell them or take too many. Urine testing, and the prescription monitoring program is a way that we now have access to where people are getting all their prescriptions, all their controlled prescriptions. It's a little delayed, we don't see, it's not live, but usually within a couple weeks it's all up to date. And it's a very good way to catch people who are doctor shopping and that sort of thing. And so that's one of the best ways we can, encourage our doctors and our, to just stay on top of this. A lot of doctors aren't using it, unfortunately. It does add time. It's a separate website they have to go to. Their staff doesn't have access yet. So there are some real barriers to this, but hopefully that will get smoothed out soon. So we know that, like I said, it'll detect aberrant behavior. This is about the prescription monitoring program we're trying to get people to access and use. It will identify those overdose substances, potential for overdoses, and it evaluates the prescribing practice. Like I might look at it and think, wow, I prescribed that much? So you're looking at it and you're reminded of how many times that person's asked for that medication over a period of time. And so it's a really good way for us to evaluate ourselves as doctors. At home, it should be locked up. If it's a narcotic, it should be, we too as parents or as partners can maintain pill counts as well. And the parent should administer to the child. And I remember one pharmacist at one of these meetings said that he was at a meeting and he saw the parent just give the prescription to the child. And it was like, no. So he grabbed it from the child and gave it back to the parent. No, you maintain control of this. And so anyway, but don't be shy about searching kids' rooms if you have children who could be into this. I mean, just stay on top of this. This is not something that a child who is going to be honest about if they're really starting to go down a path of where it's not safe. Pay close attention to those changes in behavior. Okay, and don't flush down the toilet. It's not good for the fish. Okay, right. Take it to the pharmacy. The police station does have kiosks now where you can dispose of it. Okay, but some people aren't even comfortable going to the police station. I guess some recovering addicts I've heard aren't comfortable going there. They're thinking people are watching them. So it's just crazy. So but you can mix with dirt or you can mix it with cat litter and that sort of thing and just throw it out if you want to. But it'd be best to just make sure you dispose of it if you don't need it. All right, so in summary, the increased supply and abuse of the prescription opioids is a huge problem. It's probably the most serious health crisis we're facing right now. Now, how many of us are really worried about Ebola? I mean, it's kind of scary, but I mean, when there's this many people dying in our neighborhood, I mean, we should be much more concerned about this, all right? Yeah, someone said if you had like 54 dolphin that just be washed up on shore, right? Remember that?
People would be outraged, right?
Yeah, people would be outraged, and this happens every day with the people that die around the country, about 54 every day. So, chronic use of opioids for benign chronic conditions has backfired, okay? There's no good, clear scientific evidence that it reduces pain or improves quality of life in the majority of patients. There will be some, I'm sure, that seem to function better on it. It's probably best to do a drug holiday now and then to see what it's really accomplishing. It's a tricky thing, and I think there are some people that can maintain very quality lives on chronic opioids, but it's really hard to know how it's working for them overall. Marketing efforts from the 90s and beyond stating that these are safe when used as prescribed has proven to be wrong. So we really need to understand that. And the hyperalgesia, the tolerance might explain a lot of these failures. We must all become educated and really understand these serious risks for ourselves and for our families. And the health providers are really strongly recommended to make use of the PMP, do the pill counts and so on. So we're trying to get this word out. You're hearing more and more about this on the news, and I just want you to have a better handle on it yourselves. So yeah.
It seems to me that this, since things are all prescribed by medical physicians, this conversation is better geared to doctors. How much of this is really, how much education and training are doctors getting about the effects of these pills down the road?
That's a real interesting question, because I've been given this to a lot of the medical staff at the South Shore Hospital, this sort of presentation with a little more science behind it, a little more of the details. It's received with mixed. It takes a long time for doctors to change their behaviors, and it's discouraging to me how little they want. Some doctors want to own this as being prescribers and feeding this problem. So I'm really concerned. That's why I want everyone to know, so that when they go to their doctor and the doctor's like ready to just slap them the prescription, hand them a prescription for whatever you want, you can question it, okay? And you can say, do you think ibuprofen might work? Or something like that. And I'm amazed at how often that works, okay? I'm amazed at how often when patients are saying, what would you recommend for pain? Well, you haven't tried the over-the-counter stuff yet? Go for it. And, and you teach them what the maximum dose is, and it's amazing how often that and icing and keep moving and reassurance is enough. Sometimes a short prescription will help, but yeah, challenge your doctor's notion about what you might need for your pain as well. I'm trying to get the word out. You have something.
Yeah, along those lines, because one of the figures we learned in Atlanta is that in veterinary school they have about 70 hours of pain management, but in medical schools and pharmacy school it's less than 10 hours. So and they have little of any training on addiction, so they're not being trained on it, and that there is mandating physician education in Massachusetts, but we're not sure that mandating education, because the people that do it right will get the education. The doctors that aren't doing the right thing don't get the education, and they don't want to get the education. So that's why we try to educate everybody that the drugs are dangerous, and so we're all in this. So it's not one. The more people we educate, we think the better.
Right. There are some courses through Boston Medical Center, and I think there's been questions as to whether or not they just do the education around okay, this is what's happening in terms of addiction and problems with the medications, but then they go on, but if you're going to do it, this is how to do it safely. And I think the question should be not so much how to do it safely, but is it really a safe way to do it? Is there really a safe way to prescribe it for chronic disorders? And I think we among ourselves as doctors, we need to have that conversation more, because I feel like their message has gotten more conservative over time.
Oh, it has.
At one time, I think they were
has.
feeling, like you could just go up and up. And,
a few years ago it was the training where some people are going to get addicted, so if you can screen those people out up front, you might be all right. But now the message, and they just came out this week, and the American Association of Neurologists came out and said, the evidence is clear now that taking pain medicines for the long term do not work. And they work in some cases, but the downside is much better than much more serious than the upside. And so this whole thing with hyperalgesia, things like that. And the message now is that short-term only, and if you're going to use it long-term, to have the doses below 100 milligrams. And that this thing just basically the idea before was that it all comes from the way we used to treat cancer pain. And the difference between cancer pain and other pain, with cancer pain, your goal is to remove pain into the end of life. And so there's no reason for people to die in pain in America, and that's a good message. So the pain pills do work. But what you do is that when you increase the pain medicine, you decrease function, so somebody will be without pain, but these people aren't going to work or driving cars, so it doesn't matter that they're not functioning. Or when you take the same method of treating pain for cancer and translate into treating it for back pain, the goals are different. The goals of back pain are get people back to work, get them walking and stuff like that. And the more you go up on the dose, that's very unlikely. So it's the type of pain. And then the other problem we run into with hospice too, the people who need the pain medicine at end of life, they don't want to take it because they would get addicted. Well, there's no such thing. There is no such thing as addiction in the end of life. Believe me, because addiction is more of a social, neurobiological, and so anyway. So I think that the message is coming out clearer and clearer is that short-term and lower dosages, and we'll all be better off. And that it's we're responsible too, because we can go to the doctor, we expect the pain to be relieved, so we want the strongest medicine. So, and then the other thing that we're noticing is this patient satisfaction. Now doctors and hospitals are going to get dinged from Medicare if the patient's unhappy. Well, giving
Yeah.
people all the pain medicines they want, they're gonna be happy. But that's not the best medical care. So I think there's actually an inverse relationship between the patient satisfaction and the quality of care, because if the patients are getting everything they want, and are happy, that's not good medical care. So you want, you want a doctor that's maybe not that nice to you, type of thing. I don't know if that makes any sense, but,
Yeah.
So that's the other whole thing, is
Yeah, that's
now
what
it's
I'm
all
concerned.
about keeping the patient happy. Well, it's about saving lives is what we think it should be about, not about having happy customers. So that's another whole issue.
What's the relationship between this and the heroin epidemics we're going through?
Good point, I should have.
So there's a clear correlation, and that's one of the, pushback we get from pharmacists and other people. So we hear it over and over again from Learn to Cope, especially is where I heard it mostly, is that people start out young on prescription medicines, whether it's from a dentist or something like that. And then especially the stronger the medicine, the OxyContin 40s and 80s, or the oxycodone 30 milligrams, kids like it. So they snort it the first time, they take it the first time. They get a high that they've never had, and they'll never will get again, because the first high is usually the best, and you're always chasing it. So they get hooked, and as they, it might not be the first week, but eventually they want to get that again. And then as they get it, the first supplies we know they get from their friends, families, medicine cabinets. But as that goes on, they can't, there's only so many friends and families' medicine cabinets you can raid. And so then when they can't scam doctors anymore and stuff like that. So the prescriptions, if it's OxyContin and you're using 80 milligrams, 3 of those a day, you've got a $200 a day habit of prescription drugs. So that, there's not too many high schoolers and college kids. I mean, you can afford that. So the bottom line is, heroin is a lot cheaper. $5 to $50 a day would get you the same equivalent. So it's much, much cheaper. So if heroin's available, nobody starts out and go, oh, I'm going to use heroin. But they use, and the spike in the heroin use is all economics. It's much, much cheaper. And sad to say, some people say it's easier to get than prescription drugs now. So as we've been clamping down on the prescription drugs and getting people to throw them out, heroin goes up. But hopefully some people will be saved too. If you can stop those initiates starting, we'll be better off long range. But in the short term, we are going to be seeing more overdose deaths. And a lot of the overdose deaths, because we look at them at Norfolk County, a lot of them are heroin, but most of them are prescription drugs. And there's prescription drugs involved. Yeah, it's about 2/3. We notice that. And then the other big thing that we've heard about, and we're actually starting to see, almost always involve multiple drugs and alcohol. So nobody just takes one drug. They take multiple drugs, and they take benzodiazepines, which is the Xanax, the alprazolam, and the Klonopin. So those in particular, in them themselves, are very addicting, but they're not all that dangerous. But when you mix them with the opioids, the death rates skyrocket. And so that's the message we need to get out to doctors, that these are not safe drugs to use in combination. And then it's even crazy that you see people given pain medicines, benzodiazepines, and sleeping pills. So that three combination, you're just depressing the brain, and then you add in, like Janet said, sleep apnea, obesity, COPD, and people in their 40s, 50s, and 60s are dying unintentionally on doses that are prescribed by the doctors. So it's not like they're taking the whole bottle, they're taking it. And the other sign that we happen to see in some of the reports too is that there's, this loud snoring. Well, loud snoring is a sign of sleep apnea, but loud snoring on somebody on opiates, that's a sign of an overdose, and that they may not, and what you hear anecdotally is that, the wife can't stand the noise of the snoring. They go to the other room, go back to wake up the husband's dead. So when you hear that, I don't know if you know that, but if you hear louder snoring is not,
I didn't know that.
it's a sign of, it could be a potential overdose. So if they're snoring loud and you can't arouse them, they are in an overdose. So that's the type of thing where people.
I live with I take care of my elderly parents, and
Mhm.
I didn't know that. That's a good thing to know.